Good morning, everybody. I'm Jim Delgonis, president of PARA, the Presidents and Regents Retiree Association. Today's session will include a presentation from Dr. John Swartzberg, followed by questions and answers. Thanks to those of you that submitted questions in advance. If you have additional questions that come up during the session, you could submit them via Q&A. If we have time, we'll address those at the end. The co-moderator or co-host for today's session is a longtime colleague and friend of mine from the UC Office of the President, Debbie Obley. And working as tech support for the session today is Carrie Sweeney, director of UC Berkeley's Retirement Center. So let's get started. It gives me great pleasure to introduce you to Dr. John Swartzberg, MD. John's a product of UC, having obtained his bachelor's degree from UC Berkeley and his MD degree from UCLA, followed by residency in internal medicine at the University of Colorado, and then study at Stanford in infectious diseases. John is a clinical professor emeritus at UC Berkeley's School of Public Health, chairs the editorial board of the School of Public Health and Wellness Publications. He's past director of the UC Berkeley UCSF Joint Medical Program and continues to teach in that program. For 2 years, he was president of the UC Berkeley's Emeriti Association. Please join me in welcoming, I guess virtually, Dr. John Swartzberg. John, you're on.
Thank you, Jim. And thank you everyone for joining me today to talk about, of course, what everybody is talking about, and that is COVID. So let's get started. I'm going to speak to you for about no more than 30 minutes because Jim and Debbie and I just thought that you would probably have lots of questions, and I'll certainly try my best to answer them. So let's get started. Here's my agenda for today. I'm going to essentially try and answer these questions. What do we know about immunity? Can we get reinfected? What is herd immunity? How extensive is this pandemic? How is the virus transmitted? When are we contagious? And what about vaccines? So the first question that I want to address is, what do we know about immunity? Well, we know that the human immune response, and I promise not to go into all the science about our immune response, but I wanted to lay just a little framework. There's two types of immune response that we have when we encounter something that's foreign to us. One is what's called innate immunity, and that's an immune response that is not specific. It's that we're born with it. It's been something we've evolved with. And so anytime there's a foreign invader, we non-specifically will respond to it to try and kill it. And in terms of SARS-CoV-2, the virus that causes COVID-19, we do have an innate immune response to this virus. It's the acquired immunity that allows us to get well. The innate immunity can hold the virus at bay for a little bit, but it's the acquired immunity that cures us. And there's two types of acquired immunity: humoral, which means antibody type of immunity, the antibodies we produce, and cell-mediated immunity, which are the cells that can kill infected cells with the virus. And we have both of these responses to SARS-CoV-2. We know that humoral immunity, and more specifically, the immune response to develop antibodies to what's called the spike protein, is what's critical. But we also think that cell-mediated immunity is terribly important. For both of these types of immunity, we have memory, and that is that when the virus is gone, we can remember it. So if we encounter it again, hopefully we'll respond much more quickly to it. And that becomes important in some of our discussion. So that's pretty much it for the science. But what do we think about when we think about the immune response to SARS-CoV-2? Well, there are a few ways we can have an immune response. One is, which would be wonderful, is what's called sterilizing immunity. And that means that when we get infected with the virus, that virus can't even get into our cells and replicate. We are sterile. That is, it can't infect us. And that's the best kind of immunity because it means not only that we won't get sick, but it also means that we can't spread it to anybody else. We can't be asymptomatic shedders of the virus. It's not common that we develop sterilizing immunity from a vaccine, but it can occur. For example, the measles vaccine and the polio vaccines both cause sterilizing immunity. So we can hope for sterilizing immunity, but it's something that may be beyond our reach. We'll know in a few months. More likely, we will develop what's called functional immunity, which means that we can get infected, the virus can replicate a little bit within us, but we'll kill it off before it can make us even sick. So we won't even know we've been infected. That's good for us because we won't get sick, but we could still spread it to other people who don't have immunity. So it's not as good as sterilizing immunity. So far, the data with the vaccines that I'll talk about more in a few moments suggests that we're going to have functional immunity. We don't know whether we'll have sterilizing immunity. So that's a big question. Then, of course, the immune response that we develop I'm talking about acquired immunity, can wane over time. And one of the big questions we have about vaccines or by natural infection is how long will our immunity last before we lose it? Or maybe not completely lose it, but where it's waned so much that it's only gives us partial protection? Or will we lose it completely? So these are critical questions about natural infection or vaccine protection. So that's what I wanted to say about what we mean by immunity. Will it be sterilizing, functional? Will it wane, or will we completely lose it?
John, we've just gotten a couple of requests to speak up just a little bit if you can.
Sure. Thank you. Can we get reinfected? Second question. Well, the answer is yes, we can. But more importantly, how often will it occur? Right now, there have been 8 reported cases that have been well documented. And this report from last month in Lancet reports on the first 4. And I wanted to spend a few moments with these because I think they tell us something about what we may expect in the future. In the first case, which was the person from Hong Kong, he developed a mild infection. And then 142 days later, got infected again. And this time he was completely asymptomatic. So the first time he had mild symptoms, not requiring hospitalization. But the second time he did become infected, but didn't develop any symptoms. The first time after his infection, he didn't develop any evidence of immunity, acquired immunity. After the second infection, he did. So we know he got infected, but he didn't develop immunity. We don't understand why that was. In the second case, this person developed, was a person in Reno, Nevada, a young man. He had a mild infection with the first infection. We don't know whether he developed an immunity. There was no data about that. But the second time he got infected, 48 days later, he was so sick he had to be hospitalized. Fortunately, he survived. He had evidence of antibody immunity after that second infection. And you see the third and fourth cases here. So the things I wanted to point out with that first infection, there was no antibody after the first infection. That's disturbing. So it means you can get infected, at least some people, and they don't develop an immune response and protect themselves. But afterwards, you can develop immunity. With the second case, it was mild and then hospitalized. It suggested that you could be infected the first time, and then the second time, it could be really much more serious. So that was very disconcerting. In the case from Ecuador, a 46-year-old man, mild infection the first time, and again, like the person from Reno, worse the second time. So we have lots of questions about our immune response to this. And at least we know that in certain people, and it appears to be rare right now, you can get reinfected, and your first episode may not protect you from getting sick with the second infection. So these are important questions. And in this patient here from Reno, we know that, the first person from Hong Kong, it appeared that he had an awful lot of virus with the second infection, enough that he could easily spread it to other people. So these are some red flags about our immune response. So what is herd immunity? Well, there are better names than herd immunity. Herd immunity was actually a term developed in the earlier part of the 20th century to think about vaccines and how long it would take to get a herd of animals vaccinated before they could prevent infection spreading within the herd. Better names perhaps are indirect protection, community protection, or community immunity. I sort of like the name community immunity, but this name herd immunity seems to be sticking. So I'm going to try and talk about it in terms of community immunity. What it refers to is the prevalence or proportion of immune persons within a population. What is the proportion of immune people within a population? And it may be achieved through vaccination, or it can be achieved through natural infections. In terms of what is the community immunity we need to really prevent this virus from continuing to spread effectively, we think it's about 2/3 of the United States population, or 2/3 of the world population. So 2/3 of the herd needs to be immunized before we can really control this virus. And we can either do that through natural infection or vaccination. So what does it mean to get to that threshold? If we know that there's about 325, 330 million people in the United States, the number of Americans currently immune, probably closer now to about 20 million. To get a third of that 325 million, we'd need about 200, 225 million people either infected or vaccinated. What are the implications of this? Well, currently we have about 11 million cases in the United States, and we know that those cases have resulted in about 250,000 deaths in the United States. Well, if we extrapolate that to getting herd immunity by natural infection, as is proposed by a fringe group of researchers and physicians in the United States and worldwide, if we extrapolate that to getting to herd immunity by natural infection, we'd have to have about 18 times the number of deaths, which would mean that to get to herd immunity by natural infection in the United States could be over 4 million deaths before we're there. How extensive is the pandemic? I'm going to give you data from yesterday. I didn't pull it from this morning yet. Much of this data comes from the New York Times and some from the San Francisco Chronicle site. So worldwide, there are reported about 55 million cases. You can probably add on at least 20 or 30% to this number for the actual number of cases, but these are the reported cases. So 55 million plus, going up, and about 1.3 million deaths. And you can probably multiply the number of deaths by 20 to 30% as well. These are going up by 35% in the last 2 weeks. If we look over here in California, we've reported yesterday 11.3 million cases. That's an 82% increase over the last 2 weeks. We've reported, actually, as of this morning, we are now over 250,000 deaths. We're now over 250,000 deaths in the United States. That's gone up 40% in the last 2 weeks. And we have hospitalization data in the United States. It's gone up 46% in the last 2 weeks. And you can just look at this curve where we are, right in here. And you can see how we've built on it. So we're going up in a stepwise fashion. Here was the surge during the summer, and look at where we are now. People talk about waves, and I think it's from an epidemiologist perspective, we're really in one wave of this with some humps on it here in the United States. This is the projection for the United States. By March 1st, if we continue to social distance and wear masks at the rate we are currently doing things, we're going to have around 430 to 440,000 deaths reported. That's so we can add that. It's almost another 200,000 deaths if we don't change the way we're masking and social distancing. If we had universal masking, we could really reduce that number by about 70,000 deaths. If we ease our mandates, by March 1st, we'd have about close to 590,000 deaths. That's where we're headed with the projections. In California, we're now over 1 million cases with over 18,000 deaths. The case rate in California has gone up 102% over the last 2 weeks. Interestingly, deaths have actually dropped a touch. The number of hospitalized has gone up. Let me say a word about this. If you get infected on day 1, on average, you get sick on day 5.5, between day 5 and day 6, on average. If you get sick, you will get hospitalized on average about a week or 8 days later. So roughly about 2 weeks after you get infected, you'll be hospitalized. If you die, you'll usually die about a week or so later in the hospital after admission. And it takes roughly about a week to get the reports recorded and presented. So roughly, deaths will lag behind infections by about a month. So even though this is nice to see, deaths are going to lag behind this marked increase. So we know we're going to see increased deaths probably within about 2 weeks. And we know that with hospitalizations, we're going to see increased deaths within 2 weeks. So we're going to see increased deaths, but we're just not quite seeing them yet. This is what it looks like in terms of the color codes, where yellow is best, orange is next best, red, and purple is worst. And this is November 4th, 10th, and 16th. And we can see what's happened to the state. It's just about all purple now. This is California's data in terms of the percent positive, the total number of cases, which I previously showed you, and the total number of deaths. Right here, though, I wanted to draw your attention to the fact that the total number of deaths have plateaued, and just in the last couple of days look like they might be going up. But this is what I think is just so striking to see. This curve right here. And this is the percent test positivity. And we were down on October 1st, we were down, well, about October 15th, we were down to about 1.4% positivity. That's of the number of people that get tested, the percentage of people that are positive. And now we're up to 4.7% positivity. That's a big increase in 2 weeks. Hospitalizations, again, you see the numbers starting to go up again. These are the Bay Area counties. So Alameda County, where you see Berkeley is, we see a 140% increase in the last week. Excuse me, 15% increase in the last week, 140 cases. And this just graphs out what we're doing in the Bay Area. And so we see the same pattern that we're seeing in the rest of California. but it's better here because we started at a much lower level than Southern California and a much lower level than all the other metropolitan areas in the country. So that's why we're not seeing our hospitals as filled as places like Wisconsin, Minnesota, and Illinois, Utah, and now in Colorado. How is the virus transmitted? Well, I'm not going to spend a lot of time with this because I think most of you know this, but I wanted to bring you up to date with what our thinking is. We know that the primary way for transmission, the vast majority of cases, are transmitted by droplets that are expelled from one person to another. Most of these droplets are large and heavier than air and fall to the ground within about 6 feet. We've known this for a long time. This is the most common way the virus is transmitted, being within 6 feet of somebody and getting these larger droplets on us. We also know that we expel smaller droplets that can be lighter than air, particularly these ones that are less than 5 micrometers. And these can remain in the air for a number of hours, and they can travel much further than 6 feet. But when you're outside, they get dispersed so much that it's almost never an issue. Inside, though, these small droplets, because there's not a lot of air exchange, can get concentrated enough to infect us. And there are documented cases that are very compelling where small droplets have spread this. It's much less common than larger droplets, but it becomes important with the weather being colder and people being inside. Direct contact with someone's contaminated hands, or direct contact with inanimate objects, which we call fomites, that have the virus on them. We don't know how important it is. We feel it's far less important than the larger droplets and probably far less important than small droplets. But because we don't know, it remains prudent, of course, to wash your hands or to use disinfecting alcohol on your hands. So most important transmission is larger droplets, and we've known this for a long time, but the data consistently continues to show that. Two things we have learned about transmission that I wanted to make sure you're aware of is what's called asymptomatic spread. We learned this in the late spring. That means if you get infected right here, you start to shed virus enough to spread it right about here, and you'll spread it for about 10 days, but you'll never get sick. Interestingly, even though you're shedding less virus than somebody who's symptomatic, you're spreading enough to cause somebody else to get infected. And because you're asymptomatic, these people often are not careful, or as careful as somebody who's symptomatic. If I'm sick, I'm going to be staying home. If I'm not sick, I'm going to be going out. And we know that probably about 40% of all infections result in asymptomatic infection. And this is a major driver of this pandemic. There's also, you'll hear the term pre-symptomatic spread, and that's where you get infected. And then when you become contagious, you're contagious for 2 to 3 days before you become symptomatic, probably closer than 1 to 2 days than 2 to 3, but let's say 1 to 2 days. And then you become sick. And so you can spread the virus before you become ill and before you're taking the precautions you would take when you are ill. So these have been major drivers to spreading this virus, asymptomatic spread and pre-symptomatic spread. Which then raises the question, when are we contagious? Well, here's when we become infected. Let's say day 1, or 5 days before we become symptomatic. This is the line of where we become symptomatic. And I'm just going to draw your attention to this dotted curve here. You can ignore this curve. So if we're infected here at day 1, we typically are going to become contagious 1 to 2 days before, and will remain contagious typically for several days thereafter. So for a period of about 10 days in total, probably closer to 9. But notice this curve here. This is the peak amount of virus we have. It's called the cycle threshold, but it reflects the amount of virus we're shedding. And the peak amount of virus we shed when we get infected with this virus, the SARS-CoV-2, is about a day before we become symptomatic. We are most contagious with this virus about a day before we become symptomatic. That's not the case with influenza. While the virus may be shed up to 12, maybe 24 hours before, the virus is in its greatest concentration in our mouths and nose, in our airways, when we become symptomatic. So this has enabled SARS-CoV-2 to spread with much greater alacrity than influenza virus. What about vaccines? Well, clearly there's a lot of exciting news about this, and I'll answer some of your questions now, but I suspect there'll be a lot more. So we know we're on clearly a rapid development course. This is the length of time it's taken to develop these other very effective vaccines. And here we're talking about less than a year to have an approved vaccine, or at least one that's given emergency use authorization. It's really remarkable. Our technology has really made this possible, the technological gains in the last 2 decades, primarily. Lots of vaccines in the pipeline, phase 1, phase 2, phase 3. There's also what's called phase 4, by the way, and that's after a vaccine's approved. We'll continue to monitor people who have been vaccinated, not nearly as carefully as in these phases, but we still need to learn about side effects and efficacy. By the way, all of these cartoons are taken from the New York Times, really good website on their vaccine tracker. Almost all the vaccines we're talking about are centered around the idea of producing an antibody to this spike protein. This is the spike protein on the virus. Here's the virus. And it attaches to receptor sites on our cells, specific receptor sites called ACE2 receptors that are found throughout our body, but predominantly in our respiratory tree. And we have learned that if we can block the ability of this spike protein to attach to that receptor, as you see here, if we can block this, we think that that's the way to prevent us from getting infected. That's what basic science that we learned in the first 6 months of this pandemic taught us. And almost all of the vaccines we're developing are centered around this concept to block the ability of the spike protein of the virus to attach to the ACE2 receptor on our cells. Once it attaches to that receptor, it pulls the virus inside of our cells, and then the virus can start to take over our cellular machinery to reproduce itself. That's how it can survive. So here are the vaccines we have. I'm particularly proud of this slide because I finally learned how to make this kind of slide. It took me a while, so I'm really happy that I figured this out finally. Of course, my 13-year-old granddaughter could have taught me this in 2 or 3 minutes. I should have asked her. In any case, these are the different groups of vaccines that we've produced. Some are genetic vaccines, the ones that we've been hearing so much about, Pfizer and Moderna. They're inserting the messenger RNA that codes for the production of the spike protein. They took that messenger RNA, put it in a lipid coat so it doesn't get destroyed by our body when it's injected in. It gets inside of our cells, and our cells start to produce the spike protein. Our immune system recognizes the spike protein as foreign, that acquired immunity that I talked about, humoral and cell-mediated. We recognize that spike protein as foreign, and we develop antibodies to it, and we developed a cell-mediated immune response to it. And those antibodies to it, we know, block the ability of the virus to get inside of our cell. That was what we thought would happen, but we needed a proof of concept. And very excitingly, we got that proof of concept announced a week ago last Monday with Pfizer's vaccine. It did produce antibodies, it did produce blocking antibodies, and it did, according to the press release, not a scientific paper that's peer reviewed, it did prevent people from getting sick and getting infected. So very exciting. And then waking up a week ago on Monday of this week, we heard about Moderna. And again, comparable efficacy. And today we heard more about Pfizer, that they've now gotten to 170 patients from the 96 that they originally had. It was up to about 95% protection. And I can talk more about that. But there are other types of vaccines that are being made. There are viral vector vaccines. Johnson & Johnson in this country is doing that, as is AstraZeneca. CanSino and Gamaleya from China and Russia not only have produced these are using DNA in a adenovirus, put into an adenovirus that's innocuous to us, but the adenovirus will cause it to replicate inside of us. It's been used in China and approved for use in China in their military and approved for use in Russia. Neither of these have gone through phase 3 trials. Something that would not be done in the West. There are protein-based vaccines. In other words, we take that, just the spike protein, and inject it into people. Sanofi's working on this, as a couple of others, plus 11 others here listed here. So we inject that protein into us, and we develop an immune response to that protein, the spike protein. And then there's whole virus that is either killed or attenuated. And in China, they're using one of these, but it's not been approved yet. So a variety of ways to do it, but these are the genetic vaccines with the RNA are the ones that are very exciting. The DNA vaccines have not been used yet. So here are some of the known knowns. This is apologies to Donald Rumsfeld's famous known knowns and known unknowns and unknown unknowns. The known knowns are that we know now that people will develop antibodies to the vaccine, and these antibodies appear to protect us. That was a critical thing to know, because a lot of things that make sense aren't true. And we had to prove this, and we now have proof of concept. There are some known unknowns, things we know we have to look for. What is the duration of immunity after vaccination? We don't know. We know that we have produced some vaccines, like to Haemophilus influenza type B, that we give to kids, that the immunity you get from the vaccine is much, much better than the immunity you get from natural infection. Longer duration, more robust. Will we see that with this vaccine? With Moderna's and Pfizer's and others that may be developed? Will it be less good than a natural infection? We don't know the answer to that. Will the immunity be sterilizing? We don't know. And that's so important, again, because if it is, then somebody who's vaccinated won't spread it either. What effect does age, sex, ethnicity, race, socioeconomic status have on our immune response to the vaccine? We got a glimpse of that today when we heard about the Pfizer vaccine. It did appear that it worked in people over 65 did appear to get protection from it. They developed neutralizing antibodies, and it appeared to protect them from getting sick. So it appeared to work in an older group, and older people don't respond as well to vaccines as younger people. We don't know the data about sex yet. There were not a lot of different ethnicities within the trial that got sick, so we don't know enough about ethnicity and race yet, or socioeconomic status. The safety profile, the report we got from the 170 people who got sick with the vaccine, and also the 44,000 plus people in the Pfizer vaccine, and the close to 44,000 that we've got in the Moderna vaccine, all suggest that the side effects from the vaccine appear to be very mild. With the Pfizer vaccine, the report today, again a press report, said that the older people tended to get fewer side effects than younger people. We don't have long-term data on safety, obviously. And that's a critical piece of information that we need. So the safety profile is very incomplete at this state, but we know that people aren't getting the vaccine and getting serious sequelae yet. Again, it sounds like a lot of people, Pfizer will have close to 66,000 people in their study, half of whom will have received the vaccine. That sounds like a lot, but when you're talking about immunizing 2/3 of the world's population, or about 4 billion people, we know we will see side effects, and we will know some of these will be very serious. And what will be the impact of the vaccine about people who are vaccine hesitant? You know, producing vaccines don't help. It's getting the vaccine into people that helps. And how many people will not want to get vaccinated because of the constant prevarication from the Trump administration? People don't trust what we hear out of the White House because of the politicization of the FDA and the CDC. People don't trust what they hear from those two critical organizations because they're not hearing from the senior scientists and the wonderful people working in those institutions. We're hearing from the political appointees by the Trump administration. So people understandably are hesitant about the vaccine and the distribution issues. Pfizer has a real problem with the distribution issues. The cold chain that it has to maintain is minus 94 degrees Fahrenheit, something that's very difficult to do on a mass scale. Fortunately, the Moderna vaccine can be maintained at minus 5 degrees Fahrenheit, 4 or 5 degrees Fahrenheit, and can be okay in a refrigerator for up to about 30 days. So that will really help in terms of distribution. And I just want to draw our attention to the unknown unknowns. What are the things we're not even anticipating about the vaccines, good or bad, that we haven't even dreamed of? So we don't know the unknowns. I mean, we don't even know what questions to ask yet. So that's something to keep in mind. And then who's going to get it? This is from the Institute of Medicine. It's not something that is written in stone, but I think we're going to see something like this. The first people to get this are likely going to be high-risk workers in healthcare facilities and first responders. This makes a lot of sense. That's 1A. Group 1B are going to be people of all ages who are at increased risk of dying or getting seriously ill. They have underlying conditions that puts them at that risk. And people older who live in congregate settings, because we know that this is a major cause of mortality, this group. So these will be the first group, 1A and 1B. Then in group phase 2, we're going to see other groups, and you can read these here as well as I, but this will include people like me over 65, but not people like Carrie under 65. We won't see that group until we get into phase 3 and phase 4. When? It's hard to know. I think we'll have an EUA, an emergency use authorization for both Pfizer and Moderna sometime in December. Once the EUA is given, the vaccine will already be distributed to many places, and we'll start to see some people get vaccinated probably before the end of the year. But I don't think we'll see a lot of people getting vaccinated until the Q1 of 2001. I think for phase 2, that is healthy people my age, we'll probably be talking about March as the earliest, but I'm just guessing right now. So I'm going to leave you with this, hope. This was Pandora opening her box, and I use this for all my talks. She opens her box that she was told not to open, and then she realized her mistake after she let out all these evil and slammed it shut, and there was only one thing left in the box, and that was hope. So that's what I'll leave you with.
John, that was great. Thank you. So we do have questions. So let me start with one having to do with the emergency use authorization. And, when there might be unconditional authorization, and should we wait for that? I mean, you were talking about the over 65 crowd, a lot of whom are probably covered by the session that we're having today. Do they need to be concerned that this is emergency use authorization, and would unconditional authorization happen by the March, April, timeframe you were speculating might occur?
I think we're going to, yeah, that's, I can only give an opinion. Clearly, any vaccine that's approved for EUA is going to come under intense scrutiny, not just by the FDA, but by independent researchers around the country. Even as I think many people know, the state of California, along with I think 12 other states, have set up their own review boards on top of it. So I think it's going to get highly scrutinized. So I'm not worried about the use of this vaccine because we've rushed it too much and we've cut corners and we haven't looked at the data carefully enough. I think what my worry is that when we scale up to the kinds of numbers we're talking about, because we're talking about immunizing over 200 million Americans to get to herd immunity, they're going to be unknown unknowns. And the problem for us is that if we wait until we won't have any of those unknown unknowns, there's going to be an awful lot of people, as I showed earlier in that projection, who are going to die that wouldn't die if they got the vaccine. So that's the needle we're trying to thread. I'm not so concerned about EUA versus FDA approval. I'm more concerned with just looking at this phase 4. So when will I roll up my sleeve? I was talking to my wife about this last night, and I think I would by March, because I think we'll have probably over 1 million people vaccinated in the United States by then, if all goes well. She said she wasn't sure she agreed with me, but she's more conservative than I.
Okay, thanks. Deb, do you want to pursue some more vaccine questions?
Sorry, Deb, you just need to unmute yourself. I just had you unmuted for a second.
Okay. I think we've got, one of the questions that was asked was whether we know that vaccines will be as effective for young people as for older people. And I think the answer is we don't yet, right?
Yeah, that's right. The Pfizer vaccine went down to age 16. I don't know how many people were in that age group. I think the Moderna went down to age 18. So we don't know about children.
Yeah, and we don't know yet about people with, for instance, seniors with other complicating factors like heart disease or diabetes. That's still an unknown, right?
It is. I'm anxious to see the 170 cases in Pfizer's group who got sick and how many of them were older adults with underlying conditions. But the number 170 is a really small denominator. We won't really be able to answer that question until we're in the hundreds of thousands, probably.
And can you explain what 90% or 95% effective means?
Sure. If we look at, well, let's take today's example. I think I remember the numbers. Pfizer reported that they've immunized over 44,000 people. Oh, excuse me, they've either given the vaccine or the placebo to over 44,000 people. Of those 44,000 people who got the placebo or the vaccine, 170 of them became ill. Of those 170, 8 of them had received the vaccine, and 162 of them had received the placebo. So that's where you get to 95%.
So John, Deb, if I could just interject here. So let's say it's 90 or 95%, and there are multiple vaccines available, come March, April, May, June. Can an individual increase their immunity from 90 or 95% by taking multiple vaccines? Are the vaccines mutually exclusive? Can you take multiple? Would we be allowed to do that? Does it make sense to do that?
We don't know. All we have is the data. And we have Moderna's vaccine, which is very similar to Pfizer's vaccine, but there are no studies saying you get your first dose with the Pfizer vaccine and the second dose with the Moderna, and that works as well as the 2 doses with Pfizer, or that even works better, or that if we got 2 doses of the Pfizer and then we added on 1 of the Moderna or a third of the Pfizer, if 2's good, 3 must be better. We don't know that. So all we have is the data, and the data is going to dictate what we do. So if you get the Pfizer vaccine for the first dose, 3 weeks later, you need to get the Pfizer vaccine for the second dose. If you get the Moderna vaccine for your first dose, 4 weeks later, 30 days later, you need to get the Moderna vaccine for the second dose.
What about the likely compatibility of the different types of viruses? I mean, the Pfizer and Moderna are both the same kind of vaccine. What about the compatibility? I know historically there have been some vaccines, say shingles. You get the early shingles vaccine, and then there's this later shingles vaccine, and you could get that as well. But other times that's not the case. Any idea about the compatibility of these different types of vaccines?
No, we have no idea.
Yeah.
That's to be continued. We will know that answer, but we probably won't have that answer for a year or more. With the pneumonia vaccine, the pneumococcal vaccine, the original vaccine was
Right.
not nearly as good as the second vaccine, but we learned that you had to have a period of time. If you already had the original one, you had to wait at least a year before you got the other one. Otherwise, there could be more side effects. So it's going to take a long time to learn about, to be able to answer your question, Jim.
Okay.
So maybe we should switch to travel questions because we've got a bunch of those. So does research show that air travel is or is not a hotbed for developing the virus? Essentially, all air travel any of us would consider taking is certainly not required, yet many of us know individuals who have traveled and felt it was safe. Would you travel by air today?
Well, that last question is easy. No. The original question you asked is more difficult. We don't have a lot of data. The data that we have suggests that the risk of flying is very low. But let me give you the caveats to that informed my decision not to fly at this point. The first caveat is that when you're talking about flying, you have to talk about getting to the airport. You have to talk about navigating the airport. And then you have to talk about being in the airplane on the tarmac, where the air exchanges aren't nearly as good as the air exchanges once you have taken off. And then you have to talk about luck. The air exchanges in the airplane are such that if there's somebody in the airplane that's infected, that's a pretty good distance from you, it's very unlikely you're going to get infected. But how lucky are you going to be not to be sitting next to or within a row or two of that person? And that you have no control over. And given the high percentage of people infected today, means the chances of being on an airplane with somebody infected today are much greater than they were 5 months ago. Let me just digress for a moment. On June 1st, the United States was averaging 20,000 new cases a day. This last week, we're averaging 180,000 new cases a day. If those cases were evenly distributed through the United States, which they're not, essentially, it's 9 times more risky to be out and about now than it was on June 1st, when we felt really afraid about being out and about. We are really in a dangerous period right now. And I think it's pretty obvious from the slides I showed. So getting back to the airplane. So now that we've flown and we've had good luck, we still have to go through another airport, and we have to get from that airport to wherever we're going. So when you think about travel in the airplane, it's more than just the plane itself. Now, let me just contrast my opinion with my colleague here at UC Berkeley, who I enormously respect, Art Reingold. Some of you may know him. One of the premier infectious disease epidemiologists in the world. He and his wife they have 3 kids. 2 of his kids within 1 week period of time had their first grandchildren back east, one in Denver and one back east. And they said they're flying to see their grandchildren. So, right now, we have a daughter and her family, 3 grandkids in the DC area that we haven't seen in a year. And we're not going to fly back there to be with them. And we don't want them flying out here for their safety as well as ours. So I think it depends upon why you have to travel. But for leisurely travel, boy, I'm going to wait until certainly after February. I think things are going to start to get better, even independent of the vaccine in March, than they were in December, January, and February. And then I think, we're going to start seeing the impact of the vaccine if all goes well by then, which means that the percentage of positive people is going to dramatically drop, which means it's going to be safer to travel because there's less chance of you being around somebody with COVID. And if you're vaccinated, there's less chance of you getting sick, if all goes well. Big if. So I'm going to wait. We're going to fly back in the spring to DC.
Okay,
Thank you for that.
I was going to ask you when you feel you personally would be comfortable flying back east, and you're saying in the spring. What about an international trip? Does that have a different answer?
Well, the longer you're on the airplane, the greater the risk, of course. But frankly, what concerns me the most is that the vaccine distribution, and I'm sorry to have to say this, but I believe the vaccine distribution is going to follow the money, which means that the richer countries are going to get vaccinated before the poorer countries. And we, every individual on this planet, regardless of where we were born, are going to have a problem with COVID until we reach herd immunity, community immunity around this planet.
Mm-hmm.
So international travel means you're going to be traveling with people from all around the world.
Do we know, with all these cases on the rise, do we have actual research that shows what this rise can be attributed to? Is it people gathering in homes, or is it people going out to dine?
Yeah, we have hypotheses. We've clearly demonstrated episodes of what's called super spreading, where we think about 20% of the people infected spread it to 80% of the people who get infected. So that's an interesting phenomenon. But right now, here are the things that we think are driving this new surge in cases. One is the colder weather, people being inside, like you were referring to. 2 is gatherings inside with other people. Big mistake. So much more dangerous being inside than outside. The third thing is the holidays are going to drive things much further. the fourth thing is COVID fatigue. Everybody is getting just exhausted with this, and people are not able to. A lot of people are not able to be as cautious as they should be, and I think that's a driver of this. There's several other things that people speculate on, but I think those are the big drivers. Congregating, particularly inside colder weather where we know the virus does well. And then what worries me a lot about January and February here at our latitude is co-infection with or co-circulation of influenza with this, that we're going to start to see right about now. It'll rise in December and peaks in January and February.
So, John, sort of a elaboration on that point. Somebody sent a question in to us about traveling on BART to San Francisco to go to a museum. What would be your advice?
Don't do it. I would not do that. Mass transit is so important for our world and our society, but I would not go on BART right now. Frankly, if I could get to the museum and they were really restricting people to go into it, I guess I would consider it. But I'd rather take a virtual tour of the museum. There's some sites that allow you to do that right now. I just think, what I think about all of this is that I think even though we have COVID fatigue, I think we've got to just sort of reach down and say, it's more dangerous now than it's ever been. It's going to be even more dangerous in January and December and January and probably February. That I've got to find the fortitude to hang in there for another 3 months. And then it's going to be better.
Okay. So you've talked about how the virus spread in one of your slides, and we've heard that you have to be exposed to the virus for, some period of time for it to really grab hold. So I go out for a walk most every day, and I wear a mask, and so do all the people that I pass on the sidewalk. But I'm not passing them for 2 or 3 seconds. Do I need to even be wearing a mask?
Yeah, let me make a distinction here. The idea that you need to have 15 minutes in proximity with somebody to get infected is a tool that's used for contact tracing. It's how to capture the greatest number of people at risk. It's not really answering the question that I think that the person is asking, and that is, what is the risk to me?
Right.
And the risk to you comes back to luck again. If you're around somebody, particularly within 6 feet, without a mask on, neither of you have a mask on, and they've got COVID, and they cough or sneeze or talk loudly, and you're around them for just a few seconds, you could get infected. On the other hand, if you're beyond 6 feet, even without a mask, and somebody who's not symptomatic, not talking or coughing or sneezing, it's unlikely you'll get infected. So I'd look at for your walks, Jim, I would wear the mask. That's what my wife and I do. And I would try and stay beyond 6 feet from people. And I wouldn't say that, I'm only there for a few seconds, because that few seconds could be sufficient if that person is infected. So that's how I would approach this.
Okay.
I also want to finally say to you that I'm delighted that when you're taking your walk with your mask on, that everybody else you see has their mask on. My wife and I try and take a walk most days too. And I would say that we're seeing maybe 60% of people have a mask on.
Interesting. Yeah, I very seldom see somebody without a mask on my walks.
I'm in Lafayette, Where are you? You're in Berkeley.
Yeah, in the hills.
We're past the 11:30 time frame. Do we have more time for more questions or not?
I'm happy to take a few more.
Can we do, Deb, maybe we could do a few more? You want to do one?
I think so, yeah. So we hear about so many more treatments that are available now for people who have contracted the virus, yet deaths are on the rise. So why is that? Are the treatments not preventing death?
Sure. Let me first address the deaths are on the rise. Well, they are going up right now because of this new surge. But deaths in the United States have been declining. The percentage of people dying of those infected continues to decline. And that's primarily because we meaning doctors, know much better now how to treat the really sick people with COVID than we did at the beginning in the first few months of this pandemic. And it's not just the United States, but in Germany and France and England, the percentage of people who get infected that are dying has been declining. The reason that's terribly important to tell you, there are a few reasons why, but the major one is that if you get sick with COVID and are really, really sick with this, your chances of dying now are less than they were before because you can be in the hospital, in the intensive care unit, getting the kind of therapy that we know can save your life. And what's so frightening about the era or the months we're entering into now is that we could get to the point very quickly, like Wisconsin is right now, for example, where the hospitals and the ICUs are 100% full. North Dakota is another example. And so it doesn't do you any good to know that if you get into the ICU, the doctors know better how to treat you and can more likely save your life if you can't get into the ICU because the hospitals are full. And that's what we have to really guard so carefully against. So now about therapeutics. There are only 2 approved drugs to treat COVID-19. There is only 1 approved drug that has been shown in double-blinded placebo-controlled trials to save lives, and that's dexamethasone, a corticosteroid, only used for people who are quite ill. And it does reduce mortality rates, not dramatically, but it does reduce mortality rates. Remdesivir is the other drug that's approved. It has not yet been shown to reduce mortality rates. It has been shown to decrease hospital stay from 15 to 11 days, which doesn't sound like a lot, but if you've been hospitalized before, you want to get out as quickly as possible. It's safer to be out of the hospital than in the hospital for other reasons. And secondly, if you get out of the hospital quicker, it means the hospital bed has been freed up. So remdesivir is a valuable drug, even though it doesn't appear yet we don't have data to show that it saves lives. An EUA was given just, I think 2 weeks ago or a week ago to these monoclonal, one of the companies that makes a monoclonal antibody. Unfortunately, we don't have double-blinded controlled trials yet to show that it's effective. Plasma taken from people who have recovered from COVID has been given an EUA, and we don't have double-blinded control studies to show that's efficacious. That's where we are in terms of the drugs that have been approved, either approved or given an EUA. There are multiple drugs in the pipeline. Again, look at the New York Times drug tracker, and it'll point those out to you. The one that I'm really excited about, or the group of ones that I'm really excited about, one of which is being made at UCSF, is this called a nanobody. And it's a really small piece of an antibody that can be inhaled either through the mouth or through the nose. And then it, at least in ferrets, which is a good model for humans, in ferrets, if they do that once a day, it can protect them from getting infected. The human trials are just going to be starting up, But you can imagine with that, you could just get up in the morning, brush your teeth and sniff something, and you're good for 24 hours. And there are antivirals in the pipeline. Those would be absolutely wonderful in the sense that they could be used therapeutically. The minute you can stop smelling something and feel rotten or get some fever, you think you're getting COVID, you could get a rapid test, you're positive, you could immediately start the antiviral like we can do for influenza and abort the infection or make it so mild it's just like a common cold. Those things aren't available yet, but you know, there's we're 11 months into this, and we've already got vaccines that are going to be approved within weeks now, and we've already got drugs in the pipeline. We've got 2 that are already approved. I know it feels like glacial speed because it's been so painful going through this, but we're making remarkably fast progress, something unheard of in the history of medical science. It's just that in real time, this COVID pandemic has just been horrific.
John, we had a question submitted by somebody about experience and treatment after you have COVID. I'm going to read the question here. I had COVID in February and recovered and went back to work shortly before the shelter in place occurred. I now have enduring symptoms ranging from cognitive reasoning issues to neurological issues to heart palpitations and shortness of breath. Many states other than California offer rehabilitation and have quickly assembled experts in many disciplines to respond to the growing number of people that have these lingering and emerging symptoms. And the person that sent it in asked if UC has any plan to expand the response besides UCSF's pulmonary focused effort to include other disciplines to address COVID survivor syndrome. And I generalize that to not only UC, but I mean, are there plans across the state to expand the response to include a variety of disciplines to address the COVID survivor syndrome?
Right. Well, first of all, I'm really sorry that that happened to that individual. And unfortunately, that's happening to a lot of people who are recovering, who recovered from the acute infection. There's compelling data that it could be as high as 1/3 of the people who recovered from infection. At least out to 3 months. We don't have much data longer than that yet. So it's, we don't know the natural history of what's going to happen to these individuals, whether this person who wrote in, whether in a few more months they'll be fine or not. We just don't know. We don't know, even if this occurs in a small percentage of people, like 1% of people getting infected, look at the number of people we're talking about. It's enormous. So yeah, there are clinics. I would suggest contacting UCSF because they're starting up a clinic for people chronically infected, more than just pulmonary problems. I don't know whether it started yet or not, but I would inquire at UCSF about that. I don't know about Stanford or in the Bay Area, but I would inquire. I know there's been talk about it in the Sutter system and at Kaiser, but I don't know if they have clinics yet that have gotten rolling. So I'm sorry I don't have the answer to those questions. I suspect there's not as much as we need right now, but I suspect there will be within a matter of months because there's so many people like this person who wrote in.
I was going through, Jim, I was going through some of the questions that people have submitted.
Okay.
The presentation has been going on, and you know, a lot of these have been covered, like the prophylactic nasal spray and the long haulers, and you just covered that, and the degree to which you remain contagious and all of that. So I think many of these have been answered. Some are very specific to the slide they were looking at when they asked the question, and I'm not sure how relevant it is to go back to some of those specifics when we don't have the slides in front of us.
Yeah, kind of hard to go back to those.
Right. But for one question, for instance, is how's contact tracing failed? Why isn't detailed information on how COVID actually is spread available?
Well, the reason why tracing is not working as well as it should, and it's not working as well as it should, the questioner is absolutely right, is because there are too many cases. It's overwhelmed the system. And California's system, thanks a lot to George Rutherford's work in San Francisco, California's system for contact tracing is amongst the best. But there's just too many cases that are happening right now for contact tracers to get on top of it. That's the first reason. The other reason contact tracing isn't working as well as it should is because particularly early on in the pandemic, actually through July in the pandemic, we weren't doing anywhere near enough testing, and the testing was taking too long. The results were taking too long to get back. It wasn't unusual to see 3, 5, 7 days to get the results back during the summer. Now that this new laboratory is taking on a lot of the testing, we've seen a marked improvement in that. It's now at, I think, 1.4 days to get a result back. But the reason why the delay in time in terms of contact tracing, the delay in getting the results back is so important. If you don't get the results back in very quickly, it's already too late for the contact tracer to make a profound difference. So we've got to get much more rapid testing available. And there was just a rapid test approved for home testing, I think yesterday. I don't know how good it'll be, and it's not going to be widely available until the spring, but we've got to get to the point where we can get this rapid testing available that's sensitive enough so we get results pretty much immediately. I turn out I'm positive, it gets recorded, the contact tracer gets back to me and it says, who have you been in contact with in the last 48 hours? So that's how it has to work, but we've got to get the percent positivity down so we have enough people to do this, and we've got to get the results turned around much faster.
Okay, thanks. We are, a bit over time. I think we probably need to cut it off here. This has been really a great session, John. Thank you so much for spending time with us, your wealth of knowledge, and your presentation was great. Carrie, thanks for your support, and Deb, thanks for participating as a helper on this. So I think we need to just sign off here, and I know a lot of people have other things scheduled at noon, so it gives you a couple minutes to breathe between this, and John, probably your class is coming up at noon or something. So thank you all.
Thank you, Jim and Deborah and Carrie. I really appreciate the opportunity to speak to your group. So thank you, and stay healthy.
Thank you, you too.
Bye-bye.